Welcome back. This is the fourth and last lecture about the development of the heart. The intended learning outcomes of this lecture are to describe the derivatives of the common ventricle, bulbus cordis, and truncus arteriosus. These are the three remaining chambers of the primitive heart tube. Number two is to list the mechanisms of formation of cardiac septa and cardiac valves. Number three is to describe the types and causes of VSD, that is to say ventricular septal defect, and anomalies of the truncus arteriosus. Now let's start to study the fate of the common ventricle and the bulbus cordis. Both of them make one chamber called bulboventricular chamber. Between them there is a groove that appears on the outside called bulboventricular groove. On the inside, this bulboventricular groove appears as the muscular interventricular septum, which increases in length by expansion of the two ventricles outwards, like this. The gap above this septum, which is called the interventricular orifice, becomes filled out by growing expansions from two septa, which will form together the membranous interventricular septum, this one here. The two extensions are extensions from the dorsal endocardial cushion of the septum intermedium and from the proximal bulbar septum that develops in the distal part of the bulbus cordis. Now the remaining part of the bulbus cordis, which is called conus cordis, is divided by two septa, a proximal bulbar septum and a distal bulbar septum. The proximal bulbar septum that is seen here develops by two growing ridges that fuse together in the middle, similar to the septum intermedium, forming together one septum between two channels. These will form the two smooth outflowing parts of the two ventricles. That is to say, the infundibulum of the right ventricle and the vestibule of the left ventricle. More distally, that is to say upwards, we can see here the development of the distal bulbar septum. This also develops as two fusing ridges. This divides this part of the bulbus cordis or the conus cordis into the two orifices of the semilunar valves. That is to say, the aortic and the pulmonary orifices. From the walls, cusps arise as elevations of endocardium, here, here, and here. Three cusps develop in each orifice. Their positions were the opposite of their adult position. As you know, in the adult, we have one posterior cusp for the pulmonary trunk, which starts with a P. So pulmonary trunk starts with a P. It has one posterior cusp, and the aorta, which starts with an A, has one anterior cusp. This was the opposite in the fetal heart. That is to say, the aorta had one posterior and the pulmonary had one anterior. But then rotation of these cusps occur so that they change into their adult positions. The cusps at first appear as solid outward or really inward growths from the endocardium like this, and then cavitation occurs in the upper parts of them so that they look like pockets, like the pockets of the kangaroo, as you can see here. When cavitation occurs, they have upper holes so that when blood passes through the artery above and tends to come back by gravity to return into the ventricle, it fills those pockets in the cusps, so they approach each other and they touch each other and close the outlet of the ventricle. Now the final septum which appears is a spiral aorticopulmonary septum, that fills the Truncus arteriosus and divides it into ascending aorta. This too develops as two ridges that fuse together. The ridges are spiral in shape. This accounts for the spirality of this septum. This septum is mainly made by migrating neural crest cells that invade the Truncus arteriosus and form such a spiral septum. The last thing we have to say about the development of the ventricles is that at first the wall of the bulboventricular chamber was smooth, but then spongework cavitations appear in it, like those. These spongework cavitations, as they widen, they leave rough areas on the wall of the ventricle called trabeculae carni. Here they are. Some of them are large enough to form the papillary muscles. Some remain as the chordae tendineae. This is an animation that shows the spirality of the aorticopulmonary septum, which descends to form the bulbar septa and finally the membranous interventricular septum. Please notice how the aorticopulmonary septum develops as two ridges which are spiral and fuse together to account for the spirality of the outlet tract. Now, before we proceed, I have to remind you that we have 9 septa developing into the heart, into the primitive heart tube. 4 of them account for the interatrial septum. These were the septum spurium, the septum intermedium, the septum primum, and the septum secundum. The remaining 5 develop in the rest of the chambers, the remaining 3 chambers, the ventricle, the bulbus, and the truncus arteriosus. 2 of them in the ventricle, muscular and membranous interventricular septa. Then 2 in the bulbus cordis, proximal and distal bulbar septa. And then 1 developing in the truncus arteriosus, which is the spiral aorticopulmonary septum. Now we will come to discuss the sources of the 2 ventricles. Well, we can say that the inflowing part develops from a chamber and the outflowing part develops from another chamber. The inflowing part of the left ventricle is made by the common ventricle. The inflowing rough part of the right ventricle is made by the proximal part of the bulbus cordis. The outflowing parts, that is to say the vestibule and the infundibulum, both develop from the distal part of the bulbus cordis, which is called conus cordis. Now we will talk about the congenital anomalies of the ventricle and the truncus arteriosus. First, the VSD, that is to say the ventricular septal defect, which is of 2 types. We may have a defect in the membranous part of the septum, that is called membranous VSD, or Rogers disease. This is by far the commonest heart anomaly, and I have to say it is more common in males than in females. It's because of failure of development of the membranous interventricular septum. As I just said, the membranous septum develops by borrowing from 2 other septa, which is the septum intermedium and the proximal bulbar septum. The second type is the muscular VSD. The muscular VSD strangely develops by meeting of 2 spongework cavitations that face each other and open into one another. Sometimes it is multiple due to fusion of many of those spongework cavitations, and it takes the name of Swiss cheese VSD. Now we will come to the anomalies of the truncus arteriosus. At first we said that there should be a spiral septum between the ascending aorta and the pulmonary trunk. In this first anomaly, the septum here fails to form at all. In such case, we have one big artery coming from both ventricles. This case is called persistent truncus arteriosus. And as you can see here, the unoxygenated blood of the right atrium passes into this one big vessel, together with the oxygenated blood from the left ventricle. And this mixed blood passes through both the aorta and the pulmonary trunk. For that reason, this case is characterized by the development of cyanosis of the mild type. The second anomaly here, which is called the transposition of great vessels, the septum develops, but it's not spiral, it is straight. For that reason, we see that the chamber on the left side, which is the pulmonary trunk, arises from the left ventricle. The chamber on the right side, which is the ascending aorta, develops from the right ventricle. That's why they call it transposition of the great vessels. Of course, you can see here that all the unoxygenated blood from the right ventricle passes into the aorta to be distributed to the body. That's why such cases are characterized by the development of severe cyanosis, whereas the oxygenated blood coming from the lungs to the left ventricle passes through the pulmonary trunk to be re-oxygenated again. Very little of it may pass through the ductus arteriosus to reach the aorta, but after the development of the three big branches of the arch that supply the head and neck and the upper limb. Therefore, there is severe cyanosis, particularly in the head and neck and the upper limbs. Good enough that such case can be corrected surgically by cutting of the two arteries and transposition of their attachments, that is to say, connecting the ascending aorta to the left ventricle and the pulmonary trunk to the right ventricle. The third case here, the septum develops. It is spiral, but it is not in the middle. That is to say, it does not divide the truncus arteriosus equally into ascending aorta and pulmonary trunk that are of the same size. It is shifted to one side. Typically, it is shifted to the pulmonary side, resulting in congenital pulmonary stenosis. Sometimes it is shifted to the left side, causing congenital aortic stenosis, but the congenital pulmonary stenosis is more common. The last anomaly is a sequelae of the congenital pulmonary stenosis. When it develops early and the stenosis is so severe, the right ventricle pushes blood against resistance. That's why it's muscle hypertrophies. So we have, in addition to the pulmonary stenosis, we have hypertrophy of the right ventricle. And when the pressure in the right ventricle is very high, it ruptures the membranous interventricular septum, leading to membranous Vsd. All right, this is the third part of this anomaly, which is called Tetralogy of Fallot. Tetralogy means 4 components. We said 3 of them already: the pulmonary stenosis, the hypertrophy of the right ventricle, the membranous Vsd, and the fourth one is called overriding of the aorta. With this overriding is actually due to shifting of the aorticopulmonary septum to the right side. That is to say that the ascending aorta has a wide base that arises from both right and left ventricles. As I just said, the most common congenital heart disease is membranous Vsd, which is called Rogers disease. It is more common in males, whereas ASD is more common in females. The Tetralogy of Fallot is the commonest cause of neonatal cyanosis, that is to say, a blue baby. Now, we said that there are 9 septa that develop in the cardiac loop, 4 in the atrium and 5 in the ventricles and bulbus and truncus arteriosus, but they develop in 3 different ways. The first type is the development of the septum by 2 proliferating ridges that fuse together. Examples of those are the septum intermedium, the proximal bulbar septum, the distal bulbar septum, the truncus arteriosus septum, the spiral septum, and in addition to the membranous interventricular septum. The second type is developed through proliferation of cells forming one ridge. This type is represented by, for example, the septum primum and the septum secundum. And the third type is a non-growing ridge between two expanding chambers, which is typically represented by the muscular interventricular septum. I just have to add that the muscular interventricular septum develops first in this way, a fixed ridge between two expanding chambers, but it is later, it grows in length by proliferation of its cells. So in this lecture, we talked about the septation and the sources of the ventricles and the types of VSD. We talked about the septation of the outflow tracts, the bulbous cordis and truncus arteriosus, and we talked about the 4 conotruncal anomalies. Thank you for listening.